So very good evening everyone. Very good evening everyone. Hope all of you are doing good. Hope all of you are fine. A very good evening everyone. This is Dr. Ankit Goel, your psychiatry faculty. We'll be starting this session. So today's session, as this disclaimer is there, basically, we are trying to discuss recall based questions, and the motive is to get the actual question. So, we have some questions. Let us see, if there are any modifications in those questions. And of course, the final questions, good evening everyone. The final questions, of course, will upload on the PrepLadder app, right? So, we'll start with the psychiatry discussion. Again, this is Dr. Ankit Goel. Now, basically, those of you who have given the exam, I'm sure, there will be a feeling of, relief after, such hard work and preparation. So, it's, very natural, and you should, in fact, relax and unwind yourself, irrespective of how the exam went. Some students, saying paper 2 was slightly tough. So, it's always there in the exam. So, irrespective of how it went, some questions, you might have, got them wrong. So, it's always good to relax and unwind. This is very, very important. Okay, so take maybe a couple of days off, do things, which you have missed in the past, few months of preparation, meet your family members, meet your friends, do things which you like doing. Now, the goal or the motive of this, session is, to analyze the paper, especially we'll analyze the psychiatry part. We'll try to get, as close to the actual questions which were asked in the exam. And also this session will be, beneficial for students, who will be appearing for the March NEET PG 23 exam, and as well as, the future exam. Students will be giving the exams in the future, maybe next or, in the coming, future exams. So this will be beneficial. So, if we analyze the paper, especially the psychiatry, so at least, there were 6 direct questions which were there from psychiatry. So if you see the markings, so the topics which they have asked, they are similar of what have been asked in the past as well. So the topics are similar. So one question is from the basics. Clinical diagnosis question, has been asked. That has been one. Again, organic mental disorder, slightly tricky question was asked. There was one question. One question from substance, use disorders has been asked. This is surprising. This time there has been no question on alcohol. Generally, alcohol is, one of the favorite topics that is not being asked this time. And of course, psychopharmacology, there has been 2 questions. Okay, so we'll discuss. And of course, there is one more question. So one more question may be from forensic psychiatry. So this question may be an overlap between psychiatry and forensic. So if I ask you, how has been, how was the, severity level? If I ask you, so how would you say, how was the severity level? So those who have given the exam. So, after seeing the, psychiatry portion, I will say it was, it was moderate. It was neither very easy, I would say, but neither it was very difficult, because, if you see the options, you would reach to the answer. Okay. So let us start with the first question. So the question is, a 27-year-old patient presented with complaints that the aliens are communicating with him, and they are sending electromagnetic radiations to his brain, and the aliens are asking him to kill his distinct relatives. His relatives said that he has, disease for 20 years. So duration also they have given. And the patient does not work on farm, he was working previously and stopped working, stopped going to social gatherings. Patient is aware of time, place and person. Okay, so what is the diagnosis? So this is, this is the closest we could get. Okay, you can tell if there is any difference. Okay, so now please see, this is a very interesting question. Now, use of getting clinical questions is that you get a lot of information which can help you to reach to the diagnosis. Now, if you see, you can see what is this symptom that, they have been telling him. So he's been hearing voices from the aliens that are telling him to kill his relatives. So what is this symptom? Can anybody tell me? So this is very, very important to identify these symptoms. In clinical questions, if you identify these symptoms, you'll be able to mark the question correctly. So can anybody tell me what the symptom suggests you? The symptom suggests patient is having hallucinations. Okay, this is telling you that the patient is having hallucinations. Okay, so his neighbor was sick because of the same disease. Okay, so this point also somebody is adding, very good. So it seems like, the patient, yes, patient is having auditory hallucinations, very good. And also if you see his social, again his social life has also been significantly impaired, which has been mentioned in the end. So what is this, what is this telling you? That he is not going to his work, he stopped socializing. What is this telling you? His social activity, work activity has significantly impaired. What is this telling you? Again, this is very, very important. So you need to identify his functioning. Functioning is significantly impaired. Significantly impaired. His social work, activities have significantly impaired. Okay, and also of course very important is the duration. Okay, duration, very good. It may be, yes, very correct. So some part maybe they are trying to tell you some negative symptoms, or also it is telling you that the functioning is significantly impaired. Now if you see the options, the first two options, that is depression, some students said that the option was depression with psychotic symptom. Let it be. Okay, let it be depression or depression with psychotic symptom. If you see both the first two, what are these? Depression and mania, what kind of disorders these are? Okay, what are the disorders? What kind of disorders are these? Can you tell me? These are mood disorders. So there has to be abnormality of mood. There is no such mention of abnormality. Okay, now let's talk about the next two situations, that is delusional disorder and schizophrenia. So we'll come back to this. So we have discussed diagnosis of schizophrenia. There are 5 criteria. Patient may be having delusions, which are false, fixed, firm ideas or belief held with extraordinary conviction. Okay, these are beliefs, false beliefs. Hallucinations, these are false perceptions. So in the question, patient is having auditory hallucinations. Then third is disorganized speech. Disorganized speech, all your formal thought disorders like loosening of association, okay, neologism, okay, these are included. Okay, so again no such symptom. Then catatonic behavior or disorganized behavior. Can anybody tell me some catatonic symptoms? Can you just remember any of the catatonic symptoms? Like there is mutism. Any catatonic symptom that comes to your mind? Anyone? Waxy flexibility. Okay. Echolalia, echopraxia, these are catatonic symptoms. And lastly, negative symptoms. So some of the negative symptoms like anhedonia. There is anhedonia. What is anhedonia? There is decreased interest. There is decreased interest. Avolition is there is decreased will to do things. Decreased socialization. Decreased socialization, again that is again some of the symptoms like decreased socialization again is seen in this question. Affective blunting, decrease in the expression of emotions, and there is decreased alogia is alogia. Logia means word, decrease in the verbal output. So these are negative symptoms. Okay. So if you see, so when we make a diagnosis, we usually say in DSM-5 it is said that 2 or more symptoms should be present and at least one symptom should be from the first 3. So yes, we have one symptom from first 3, that is hallucination. Also it seems some form of negative symptom may be there. Even if it is not there, let us say only hallucinations, still if you have to choose one answer, we can choose. Okay, and the total duration of symptoms is 6 months. So here in this question it is of course exceeding, it is 20 years. So what is the diagnosis? What is the diagnosis? The diagnosis is schizophrenia. Now again there is some confusion. Now first of all, if you have identified hallucination, I am sure you will make the right diagnosis. Still, if there is some confusion, let us try to understand what are delusional disorders. In delusional disorders, as the name suggests, what is the predominant symptom? One or more delusions. So patient has predominant either one or more delusions which may be related. For example, there is delusion of persecution towards the neighbor, that neighbor wants to kill me. Another delusion, again same, that my neighbor is talking about me. So delusion of reference. So it may also be related, and these are persistent. Okay, they are continuously present. Hallucination, on the other hand, in delusional disorder are usually absent. This is very important, and if present, they are not prominent and they occur for short duration. So everything in the question is suggesting that the patient is not having delusional disorder. Even if in the question they have mentioned delusions, you see hallucinations have been persistently present since the past 20 years. Okay. Also, one more point they have, again they have given such useful information. So, if you understand the concept well, so also you can differentiate between schizophrenia and delusional disorder based on the functional impairment. In delusional disorders, we say that the functioning is not impaired. Functioning means your day-to-day activities, social activity, work activities. Okay. So, in delusional disorder, these are not affected, and they are only affected in areas of delusion. For example, let us say, so we have made this, graph. So, let us say this is one side is schizophrenia patient and the other side is a patient with delusional disorder, and this is their activities. Okay. So, in delusional disorder, only area which is related to the delusion, only that area is affected. So, patient may not see his neighbor, may avoid meeting his neighbors, but other activities he is doing normally. He is going to the office, meeting people, all other activities are normal. While in schizophrenia, the functional impairment is throughout. All the areas of life are affected. So, again in the question they have mentioned that the functioning seems to be significantly impaired. The patient is not meeting, he is socially isolated. So, the correct answer of the question would be, so let me go back to that question. So, I hope the question is clear. So, this is the beauty of clinical questions, that you get lots of information, less chances of going wrong. So, the correct answer is schizophrenia. Very good. So, great. So, I hope it is clear. Okay. So, let us come to the second question. Now, this is again from the basics. Okay. Usually when we discuss, all the topics. So, this is, one of the basics, from the MSc mental status examination. Okay. So, first you should know the examination of a psychiatric patient is known as mental status examination. Okay. Okay. Now, please try to understand this. Okay. Now, what they have asked nowadays, this, in some, the classes, when you take in detailed classes, you always discuss this point. Nowadays, from MSc, they are asking questions like this, that you are asking patient, some questions, or you are asking patient to do something, and they are asking you that what are you assessing. Okay. So, similarly, this question again, it is, one of the predicted questions, that, patient is asked to subtract 7 from 100. So, basically you are asking the patient to subtract 100 minus 7, whatever is your answer. Generally, the instruction is to continue doing that. What does he assess? So, what are you trying to assess? Okay. So, let us see the option. Now, the first option is orientation. Now, again in the option, just let me know, some students, few students have said that, sir, D option, concentration was also there. Some have said that some different option, attention, most of you are saying was there. But just see again, see and try to, recall if concentration was there or not. Okay. So, we'll take it. So, we'll take it that if concentration was not there in the option. Any other option that comes to your mind, please do tell me. Okay. So, first, what is orientation? Orientation is basically awareness. It is the awareness of self and surroundings. Okay. It is awareness of self and surroundings. So, all of us are oriented right now, and with orientation generally we check with respect to, okay, with respect to time, place and person. Okay. With respect to time, place and person. Okay. So, you know what is the time right now. So, how do we check orientation? We know what is the time, what is the day, what is the month. So, that means you are oriented to time. What place you are right now, you know it. So, you are oriented to the place. Anybody nearby you, you can see me, me, or people around you. So, you are oriented to person. So, this is orientation. Okay. So, generally when the patient's orientation is disturbed, we say patient is disoriented. Okay. Disoriented. Okay. And disorientation, you can remember D for disorientation. D for disorientation seen in delirium. It is seen in delirium. Okay. Now, also one more point, since we are discussing again, for students will be, giving the exam, let us try to discuss some of the points which may be asked. Okay. So please remember, there is a law known as Ribot's law. Okay, there is a law known as Ribot's law, which says that the orientation to time, place and person goes in this manner. That means the first orientation to time goes, then orientation to place goes, and then person, and it comes back in the reverse direction. That means once the person starts getting oriented, he gets oriented to person first, then place, and time the last. Okay, so this is a law known as Ribot's law. Okay, now, okay, so orientation is, this is how we check. So orientation is not the answer. Okay, now attention. So attention is basically ability to attend to a specific stimulus without getting distracted. Can anybody tell me what was the previous topic which we have just discussed in the last slide? So can you tell me just before this attention, what was the topic we have discussed? Okay, anybody? So if you know, if you can tell me, that means your attention is intact. Okay, you are able to pay attention to a specific stimulus. You are able to listen to me, see me, and you remember what has been asked. Okay, so attention usually is checked by what is known as digit span test or digit repetition test. Okay, it is checked by digit span test or digit repetition test. Okay, so there are two tests: digit forward test, in which we give digits and ask the patient to repeat it in the forward manner. For example, I give the patient digit 2, 7. So he has to repeat in the forward direction 2, 7. Then I increase the number of digits. So now I may give him 3, 7, 1. So, or let us say 4. Now the patient will say 3, 7, 4. So this is, so you may be asked, you're asking a patient to repeat certain digits after him. So what are you checking? What are you checking? Okay, what are you checking? So you're checking attention. So generally we say up to 5 to 7 digit number, if the patient is able to tell, then we say that the patient's attention is intact. And digit backward test is basically, digit backward test is when the patient has to repeat the digit in the forward direction. So let us say patient, we give the number 3 and 8. So patient will repeat as 8 and 3. And again we will increase the number of digits. Okay. So again, if the patient is able to repeat 3 to 5 digit numbers, then we say his attention is intact. So this is a test which is used to check the attention. Okay. Now when we check concentration, what is concentration? Concentration means sustained attention. That means attention for a longer time. For a longer time. So and generally how this is checked? This is checked by, what is the test? The test is serial 7 subtraction test or 100 minus 7 test. So this is the test which we ask. So we ask the patient to keep on subtracting 100, 7 out of 100, and don't stop, keep on doing that. So patient may say 93, then patient may say 86, patient may say 79, 72, 65. So this is why, this is how the patient may continue doing it. Okay, up to 5 times if the patient is able to do it correctly, we say his concentration is intact. Okay, so usually these are the two tests which we do for attention and concentration. Now in the question, let us go back to that question. In the question, if concentration has not been there, then attention seems to be a better answer. Okay, then attention seems to be a better answer. Again, confusion is something which may be seen in delirium, disorientation. Okay, so then if concentration is not there, then it seems to be the correct answer. Okay, so then you can go with attention. Okay, is it correct? Clear to everyone? Okay. Now since we are discussing, so basically these are basically what we are discussing. We are trying to discuss cognition. In the MSc, what we are trying to discuss, cognitive functions or cognition. Another important cognitive function which we we can discuss here is memory. Okay, memory. Again, questions have been asked even how to check memory. So again, memory is divided, again can be divided into, okay, right. So then we can go with attention. Is it clear to everyone? Right. So memory is of 3 types on the basis of duration. One is immediate, recent. If both are there in the option, then the answer will be concentration. 100 minus 7 test is a test for concentration. Is it correct to everyone? Total MMSE score is 30. MMSE total score is 30. Okay. Is it clear? Recent and remote. So I'm just trying to give some extra information here, since again related topic it is. So immediate memory, usually is the memory of the past few seconds. So something happened past few seconds, if you are able to remember, we say your immediate memory is intact. So what are the tests? What are the tests which are used to check immediate memory? So we don't have to do any separate test. All your test of attention and concentration also check your immediate memory. But if to choose one test, we'll say digit repetition test is a better test for checking immediate memory. Okay, digit repetition test, and especially the forward test. Okay, the forward test is better. Okay, because the backward test is also assessing certain other processes. Okay, for immediate, if you've done attention concentration, patient has done well, then we'll say immediate memory is also intact. We don't have to do any separate test. Is it clear? Right. Yes. Okay. Now recent memory is basically memory of the past few minutes or hours. This question has been previously asked. Okay, so how do we check recent memory? So basically the method is known as 24-hour recall method. Okay, 24-hour recall method. So basically we ask things which have happened in the past 24 hour. Very common test which we do in this is we ask the patient about his last meal. So suppose I ask all of you, what did you had in your last meal? So what would you say? So suppose I am asking you, what did you had in your last meal? Okay, so you will tell me what you had. So what am I checking? I am checking recent memory. I am checking recent memory. Remote memory is basically, remote means far off. So remote is basically memory of the past few months or years. Okay, past few months or years. So generally again this we can ask by asking certain personal information. For example, name of your school, when did you got married, when did you got selected for your job. So those things. Also some of the times certain historic events which happened during the patient's lifetime. Okay, for example, you may ask name two past prime ministers. Okay, so this is how we check the remote memory. Okay, so again this is another part of cognition which we check. Okay, I hope this is clear. Now let's come to the next question. Very interesting question. It's a bit tricky, but again if you understand this question, just let me know if there are any alterations. So this is most of the students have said this is the question. Which of the following is not? First of all, always try to see, these are the keywords we miss sometimes. So which of the following is not suggestive of medical cause of mental illness? Okay, so this is the question, this is the question which we have got. Okay, now let's try to understand what they're trying to ask. Okay, so in the classification, again in the past few videos also we have discussed that in the past the psychiatric disorders were classified, were classified as organic mental disorders. So this is again a very interesting concept they have tried to ask you. Let's try to see organic mental disorders. Okay, and functional disorders. I hope this is clear. Let's try to understand the difference. So this basically they're trying to ask you which of the factors is not suggesting you that there is a medical cause of the mental illness. So what they're trying to indirectly ask you. So organic mental disorders, when we say that it has a demonstrable cause, or it has an apparent cause. There is something inside the body. So there is some medical cause which is leading to mental symptoms, mental disorder symptoms. While functional, again this is an older older classification. They used to say that in functional disorders generally there is no demonstrable cause, or there is no as such apparent cause of the illness. For example, they used to say depression, schizophrenia. Okay, now we know even those have certain causes. Okay, so organic disorders would include let us say someone had a head injury, after which person developed some symptoms, some psychiatric symptoms. So we can see the injury, you do a brain scan, you do a CT or an MRI, you will see the lesion. Okay, so that means there is a cause. Okay, so this is what they're trying to ask. So if you go back to the question, basically they're trying to ask you that which of the following is not suggestive of an organic mental disorder, okay, or organic mental illness. So let's try to see some of the important points between organic mental disorders and functional disorders. So generally in a, organic mental disorders, we say that the onset is usually acute, sudden onset. Okay, maybe within few hours or days the symptoms would develop, while in functional disorders they may be slow or gradual. Okay, so this again about the onset. Next is, again, organic mental disorders are more seen in elderly. They may be more prone to organic mental disorder because of a lot of comorbid conditions. There may be so many other factors. Okay, while functional may be more in young age. Again, it's just a just trying to differentiate. It's not very hard and fast. Or even of course young can also have organic mental disorder. The consciousness, again this is very important. Again, consciousness, we say is may be impaired in organic mental disorders like delirium, while in functional disorder it is intact, like the question we had discussed. Okay, in schizophrenia orientation was intact. Okay, so this is again very important. So now last point, this again we always discuss this point. So if you remember this point, that is why I was saying that if you remember this point, the answer might have come to you. So if you tell me which type of hallucinations are more commonly seen in organic mental disorders, can anybody tell me what hallucinations may be more common in organic mental disorders? So whenever we discuss hallucination, we always discuss this point. Can anybody tell me? Yes, it is visual hallucinations. Visual hallucinations which are more seen in organic mental disorder, while in functional auditory hallucination may be more common. Very good. Yes, very good. CC Zabi, very good. Prashant, Ashwin, very good. So yes. So now if you look at the question, so of course name some organic mental disorders like dementia, delirium, organic amnestic disorders, okay, and functional disorders like depression, schizophrenia. Okay, so now let us go back to the question. So now can you tell me the right answer? So which of the following is not suggestive of a medical cause? So what will be the answer? Organic is suggesting, acute onset is suggesting, loss of consciousness is again suggesting. So maybe there might be some event like let us say an head injury. Okay, so answer is very good. So the correct answer is auditory hallucination. So this is again very important. Such are again tricky questions. Organic mental disorders, once in a while you get question from this topic, and this time I would say the question was tricky, not difficult but tricky. Okay, is it clear to everyone? I hope this is clear. Any doubt? Again, delirium, dementia, these are very important topic. Students will be giving the upcoming exams. This is again important from this topic. Now next question. Again substance, again alcohol was not asked this time. It was cannabis. So cannabis got a chance to be asked this time. Okay, yes. Psychiatry, I would say in FMG exams, psychiatry is of a fairly good level. Okay, it's not very easy, I would say, not very difficult, but they ask good questions in psychiatry in FMG exams. Okay, now which of the following is a common effect of cannabis? Some said it is marijuana, so I'm again taking both, so it is same. Okay, cannabis or marijuana. Okay, so let us talk about so the question was what is common. Again, if you rule out, you might get an answer. Okay, so let us try to see. I hope this was the question. Anybody has any other inputs, please let me know. I hope this was the question. Any other inputs? Anyone? Any changes? Any inputs in this question? Please let me know. I hope the substance was cannabis. I hope the substance was cannabis. Yes, very good. So many of you are marking right, answering the question correct. Very good. So cannabis, few points about cannabis which also have been asked. Cannabis is the most common illicit or illegal substance. Okay, illicit substance. Okay, both in India as well as the world. Okay, so this is a question. Great. So all of you are saying it is the same question. What is the active ingredient? What is the active ingredient? Can anybody tell me what is the active ingredient? Okay, most common. So okay, some are saying most common. So again, let us see the options. Okay, let us see the options. What is the active ingredient? It is delta 9 tetrahydrocannabinol. Okay. So first of all, so this is the psychoactive ingredient. THC in cannabis, which is responsible for the effects. So they are asking you which of the following is a common effect after the intake. Okay, so after intake, what is the common effect? So let us try to understand. So we'll come to this question. Let's come to this question. So you will answer the question. Let us talk about cannabis. So after cannabis, so cannabis is available in various forms like ganja, bhang, there is hash, charas, or there is hash oil. Okay, so it is available. So what are the effects of cannabis? So when someone consumes cannabis, so there is a feeling of euphoria. This is very, very important. So please remember, there is a feeling of euphoria. Okay, patient feels good. Patient feels good after consuming cannabis. Okay, there is a sense of time distortion. Patient a lot of time report that they feel that the time is slowing. Okay, and if you see some of the if you see the conjunctiva, this is again very important. So someone who has recently consumed, there will be redness of conjunctiva. Appetite is increased, they may eat a lot. So family may complain, he comes back, person comes, the eyes are red, he is eating a lot. Again, this may tell you that maybe he is consuming cannabis. There is dry mouth, and again there may be impaired motor coordination. Okay. Then there are other symptoms like depersonalization. Patient feels as if he is detached from the cell. Such feelings may be reported. There may be derealization. Okay, as if the world, he feels detached from the world. Okay, and sometimes even hallucinations may be seen. If it is very high dose, there may be impaired consciousness. So cannabis intoxication, delirium may also be seen. Okay, so consciousness may be impaired, especially at higher doses. Okay, especially at higher doses. So these are the signs and symptoms seen in cannabis intoxication. Now again, withdrawals may also develop within 1 to 2 weeks of cessation. Someone is consuming cannabis continuously for a long period and the person stops, then they may also feel the withdrawal symptom. Now earlier it was believed that cannabis does not have withdrawal symptoms, especially so earlier it was believed that it does not cause physical dependence. Okay, physical dependence, it was believed that does not cause physical dependence, but now we know yes, even physical dependence is also seen, and withdrawals are also seen with cannabis. Okay, this is important. Generally hallucinogens are known not to have withdrawal symptoms. Okay, so cannabis does cause physical dependence. Okay, there is withdrawal. Okay, now let us talk about the withdrawal signs and symptoms. So again, in patients having cannabis, there is irritability or there may be anxiety. Okay, sleep difficulties, they may report insomnia or very bad dreams, disturbing dreams. Again, the appetite, there it was increased, so here the appetite is decreased. Now please remember, in the withdrawal, how was the mood in intoxication? It was euphoric, there was euphoria. So how is the mood in withdrawal? In withdrawal, you see the mood is depressed, not in the intoxication or the intake. Again, this is important. Also, physical symptoms, again earlier believed that withdrawals do not have physical symptoms. Even physical symptoms like tremor, sweating, fever, abdominal pain, chills, these may also be seen with cannabis withdrawal. Okay, these may be seen with cannabis withdrawal. So now let us answer this question. Let us try to answer this question. We are talking about intake. We are talking about the intake, not the withdrawal. So depression, no. Anxiety, again it is seen in withdrawal. Again, physical dependence, again we have discussed just now, milder. Okay, milder, yes, physical dependence is also seen, and again physical symptoms of withdrawal are also seen. So of course altered consciousness would occur in high dose. Okay, so if you have to rule, you have to rule one out. Most common would be euphoria, feelings of euphoria, but a state of dreaminess with altered consciousness would be the, out of the 4, would be a better answer. Is it clear to everyone? Is it clear to everyone? Okay, 6 to 7 questions were there. 6 were, we have got 6 at least questions we have got. Okay, is it clear to everyone? So this is very, very important. Okay, so few points about cannabis which you can remember. Cannabis can cause, just few more points about cannabis let us discuss since we are discussing. So cannabis can lead to, there is cannabis induced psychosis. Okay, cannabis can lead to psychotic symptoms like delusions, hallucination. This is also known as hemp insanity. Okay, hemp insanity. Okay, cannabis also, please remember, so this is induced psychosis. So once the person stops cannabis, generally the symptoms would resolve by a month. So that means they're induced by psychosis. Cannabis also independently, there is a increased risk of schizophrenia. Person who consumes cannabis, okay, may also develop the independent schizophrenia. Okay, diagnosis of schizophrenia may occur. Okay, so this is again. Then cannabis is also associated with amotivational syndrome. Amotivational syndrome. Again, this may be associated with cannabis. Okay. So amotivational syndrome occurs generally in patients who are consuming cannabis for a long time. Amotivational means patient, loses the motivation, loses the willingness to do any tasks. Okay, so patient may just sit, he may gain weight, okay, may appear lethargic. So this is amotivational syndrome associated with cannabis. Cannabis also can cause cognitive impairment. Cannabis can also cause cognitive impairment. Okay, so long-term use of cannabis can also cause cognitive impairment. Then also phenomena like flashback may also be seen. Okay, so I'm just naming some of these phenomena. Okay, even phenomena like bad trip may also be associated with, okay, with cannabis. So these are some of the terms you should know are associated with cannabis. I hope this is clear. Right. Now let's discuss the next question again. This is, again fairly, again we have discussed, in especially mood disorder, treatment is very, very important. Okay, so 35-year-old man was taking medication for depression but had developed sexual dysfunction. Which drug will you switch him on to address this problem? Okay, is it clear? Now see the options. Again, the options are escitalopram, venlafaxine, bupropion, TCA, tricyclic antidepressant. Some said that there is a name, maybe, imipramine was mentioned. Okay, let me know if this was the question. Any changes, let me know. So yes, so this is again this has been repeated, this point, topic from this have been repeated many a time. So let me just give you an overview of some of these drugs, some of the important points which have been asked. Okay, so what is escitalopram? It is a SSRI. Okay, it is selective serotonin reuptake inhibitor. So some side effects of SSRIs, again questions have been asked, again in many forms on this. So again, let us talk about some of the side effects. So GI side effects, nausea is the most common. Then it can cause diarrhea, anorexia, dry mouth. Again, there was a past question in which they had asked which of the following is not. Okay, and one of the option was there was excessive salivation. No, it is dry mouth which is seen. Okay, constipation may be seen, especially with drugs like paroxetine because of anticholinergic property, and weight gain may be there. Then CNS side effects like anxiety, insomnia. Some patients may report of sedation. Vivid dreams, again this is also a important side effect which many patients report. Sweating, seizures, and even EPS may be seen. Sexual dysfunction, this is again very, very important. Sexual dysfunctions, okay, yes, sexual dysfunction, most common side effect with long-term treatment. So yes, SSRIs like escitalopram have sexual side effect or sexual dysfunction. Okay, so this would not be the answer. So there is decreased libido, delayed ejaculation. This delayed ejaculation, this concept we use in the treatment of premature ejaculation. So there we give SSRIs to increase the time. Okay, and it may also inhibit orgasm. Okay, right. Now other side effects like hematological, there is also functional impairment of platelet aggregation. So there is a risk if someone is taking escitalopram along with drugs like NSAIDs. Okay, so non-steroidal anti-inflammatory drugs, there is risk of bleeding. And miscellaneous side effects like hyponatremia, which may be associated especially in elderly. Okay, then allergic rashes, hypoprolactemia, these are miscellaneous side effects. So yes, we know SSRIs, they can cause sexual dysfunction. Now SNRIs, this has again been an old question, again previous question of FMG exam. They had asked which drug affects serotonin and norepinephrine. So they were indirectly asking you name an SNRI. So selective, so serotonin norepinephrine reuptake inhibitor or SNRI. So some of the SNRIs you can remember: venlafaxine, desvenlafaxine, duloxetine, levomilnacipran, milnacipran. Right? Very good. Now just point about TCA again. TCA toxicity has been many times asked. Okay, so that is tricyclic antidepressants, toxicity can cause CNS symptoms like altered sensorium, respiratory depression, seizures, CVS, symptoms like hypotension, ECG changes, especially, QRS, that is increased, increased to 100 millisecond. Again, it is a point, that you should, start some treatment. We'll discuss that. And even autonomic nervous system like dry mouth, blurred vision, urinary incontinence. So basically the question generally is asked is how will you treat, especially when the QRS, is more than 100 milliseconds. So generally, again, there is metabolic acidosis and the treatment is IV sodium bicarbonate. Okay, this point again you can remember in the TCA toxicity. Okay, so we try to alkalize. Okay, now let's come to the drug that is bupropion. What is bupropion? It is a NDRI. What is it? Is norepinephrine dopamine reuptake inhibitor. Okay, so there is a low risk, it has low risk of sexual dysfunction. So it is one of the drugs which has least sexual side effects. Of course, it can cause again sedation, weight gain, again they are low. Okay, so these are low risk of these symptoms. So low risk of sexual dysfunction, sedation or weight gain. Okay, yes, one important side effect which you should remember of bupropion is it can cause seizure, especially at higher doses. So generally bupropion is contraindicated in a patient who has seizure disorder. Okay, there is a seizure disorder, you should not start bupropion. Also, patient having or there is a past history of having eating disorders like bulimia or anorexia nervosa. Okay, then also you should not start bupropion, because in bulimia and anorexia there is increased risk of seizure, because maybe because of electrolyte dysfunction in bulimia, in anorexia maybe because of starvation, poor nutrition, so there may be increased risk. So you should not start. So this is contraindicated. You should also know this. This is very, very important. Is it clear to everyone? I'm trying to give you all the possible, again one important, since we are discussing bupropion, let's try to discuss some of the uses of bupropion. Can you tell me all the uses, important uses of bupropion in psychiatry? One, of course, it's an antidepressant. It's an antidepressant, very good. Some of you have already mentioned, yes, Saurabh, very good. It is also used for smoking cessation. Smoking cessation, very good. Very good. So this has been asked, antidepressant used for smoking cessation. This is again has been asked. So very good. Any other use, can you tell me? So this is FDA approved. Smoking cessation, yes, it is an approved use of bupropion. Can anybody tell me any other use? Yes, we have discussed in as an antidepressant we can use it. Any other use? It is not FDA approved use which I am asking. Something related to child psychiatry, anything comes to your mind? Bupropion may be used in anybody? Bupropion, anybody, any in child psychiatry, even in ADHD. It is not FDA approved for ADHD, but it may be used in ADHD. Okay, so these are some of the important uses of bupropion. Any other antidepressant? Any other antidepressant with less sexual side effect? Can anybody tell me? Can anybody tell me any other side effect? Any other antidepressant with less or least the least sexual side effects? One more drug you should remember. One more drug you should remember. Anyone? What is that drug? Starts with M. Anyone? What is that drug? Can anybody tell me? Mirtazapine. Mirtazapine. Okay, mirtazapine is also having less sexual side effect. Is it clear? So we are trying to so since this question is asked, and this especially side effects of antidepressants, this question has been repeated multiple times. Okay, is it clear to everyone? Now lithium. Lithium is something which you have to remember. Lithium is the star drug for your, especially for your MCQ. But it's a very important drug, every time you're getting question. Now this time they've given a very interesting question. Now they've, just added a lot of points about lithium and they asked you. So just see the question and tell me if this is the right question or any changes. A 25-year-old female having bipolar disorder, she is on lithium. And which of the following is incorrect? You have asked which of the following is an incorrect statement about lithium. Okay, just let me know if this is the question which was asked. Any changes in the question I'll discuss. Again, lithium is a very important topic. Okay, so in any exam you're preparing, you should not leave lithium. Lithium is very, very important. Yes, it is right. So you're saying yes. So Satish is saying it is right. Okay, so let us understand, few points about lithium. So lithium, it's a mood stabilizer. Lithium is a mood stabilizer. Can anybody tell me chemically what is lithium? What is lithium? It's an element. Okay, so it's an element. Now, some of the side effects, let's talk about some of the side effects. Now, neurological side effect is, one of the common neurological side effect is it can cause tremors. Okay, it can cause tremors with a frequency of 8 to 12 hertz. It can cause tremors. Can anybody tell me what is the treatment of lithium induced tremors? Okay, can anybody tell me what is the treatment? How do you treat lithium induced tremors? Which drug is used? Which drug is used generally? Can anybody tell me what is the drug? It is beta blockers like propranolol. Okay. Okay, so treatment is with propranolol. Now then other side effects like endocrinal side effects, and in endocrinal side effect, hypothyroidism. Hypothyroidism is again very important. It can also cause hyperthyroidism, but hypothyroidism is more common. Okay, lithium, again it interacts with the thyroid gland. One of the things it do is decrease the release of the hormone. Okay, so it can cause hypothyroidism. This is again very important. So that is why a patient on lithium, generally by every 6 to 12 months we do a thyroid function test. Okay, this is very important, and especially in hypothyroidism the risk is more if the patient is a female, and if a patient who is on bipolar disorder and the patient develops rapid cycling, again in such patient also the risk of hypothyroidism may be increased. Okay. Now then in renal, one of the common side effect is it can cause polyuria and also then secondary polydipsia. Okay, and it can also lead to diabetes insipidus. Okay, so basically lithium inhibits the effects of ADH, antidiuretic hormone, so it causes polyuria and secondary polydipsia may be seen. Okay, so this is again. Now in the treatment, how do we treat this side effect? So the side effect is treated by fluid replacement, and also we can use drugs like thiazide or potassium sparing diuretic. Okay, we can use these diuretics also. Okay, so basically what happens is these diuretics, they cause hypovolemia, and that leads to absorption of sodium and water in the body. Now please remember this one simple concept. This will be very handy. This concept will be very handy for you again, that the body treats lithium just like sodium. Okay, so body treats lithium like sodium. So the way they treat sodium, similarly the way it treats lithium. So what happens is any condition in which sodium decreases. Okay, for example, let us say someone is having dehydration. There is diarrhea. Okay, any such conditions in which the sodium level decreases. So what will happen? The body will try to reabsorb. Sodium. Okay, and also it will also try to reabsorb lithium. So there will also be increase in the lithium. Okay, so the body treats lithium the way it treats sodium. Okay, now in the thiazide, called potassium sparing diuretic, as we have discussed, the treatment for polyuria. Now what happens is whenever we start thiazide drug, okay, in a patient, we always reduce the dose of lithium. Okay, this is again very important. So nearly to half dose we reduce. Why do we do this? Because thiazide decreases lithium clearance. It decreases lithium clearance. Okay, so what happens if the lithium clearance is decreased? The serum lithium levels will be increased. It can cause toxicity. So again, this is an important point. Okay, please remember this point. Okay, is it clear to everyone? Great. Now before this, can anybody tell me any other, not so common, but any other renal side effects? Can anybody tell me renal effects of lithium? Anybody? Can anybody tell me any renal? So let us discuss here itself. It can also cause interstitial fibrosis. It can cause interstitial fibrosis. It can also cause nephrotic syndrome. Okay, these are not very common, but some of the renal again side effects which can be there. Okay, it can also cause renal tubular acidosis. So these are some of the other renal side effects of lithium. Is it clear to everyone? Is it clear to everyone? Then dermatological are there. Yes, acne, psoriasis, alopecia, hair fall can be there. Rash can occur. Okay, again this is very important. This point indirectly they try to ask. In some last time in another exam they had asked in match the following, they had asked the teratogenic effect. Twice they've asked this question in the treatment. So this is very important point they are asking again and again. Teratogenic effect. So if a lady, she is pregnant and she consumes lithium, so what teratogenic effect can occur in the baby? There can be cardiovascular effect, that is Epstein anomaly. Epstein anomaly can occur. Okay, it is a cardiovascular defect. Okay, the incidence is not very high. Okay, but yes, more than than the general population, 1 to 2 per 1000 births. Okay, so Epstein anomaly can be seen. Now again in this, can anybody tell me, suppose patient has mania and the patient is pregnant. Okay, is pregnant. What is the drug of choice in this condition? So ladies, she is pregnant, she has developed mania. Okay, what will be the drug? What will be the drug? Very good. Can anybody tell me? Drug of choice would be, so we have 3 drugs: antipsychotics, lithium, valproate. Which will be the preferred drug in this situation? It will be antipsychotics. Antipsychotics, they are not shown to have any teratogenic effect. Okay, antipsychotics. Then second, if antipsychotic is not there in the option, then you can go with lithium. Okay, then you can go with lithium. So generally it should be avoided as much as possible. If you don't have any option, you can still, and you can monitor. You can monitor through the ultrasound and through the echo, you can monitor. Okay, and last is, you should try to avoid valproate. You should try to avoid valproate. What is the teratogenic effect of valproate? Anyone? What does valproate cause? Can anybody tell me teratogenic effect? Okay, it can cause neural tube defect. Okay, it can cause neural tube defect. Okay, now let's talk about another important topic. Again, this has also been asked. So lithium has a very narrow therapeutic index. The therapeutic range is 0.5 to 1.5 milliequivalent per liter. Again, different books have different again the ranges. Again, this is from the latest books which I am trying to give you. Again, there are some variations. Very good. Yes, that was neural tube defect. Very good. Now in acute mania, generally we say the level should be 1 to 1.5 milliequivalent per liter. In maintenance, we say 0.6 to 1.2 milliequivalent per liter, and toxicity generally occurs if the level is more than 1.5 milliequivalent per liter. Now, whenever we check the lithium levels, this again question has been asked. Whenever we check the lithium levels, generally when do we check the lithium levels? That is, how much time after the last dose. So generally we say, to check the lithium levels, we take the blood sample. This is again, this has been asked previously. So the blood sample to check the lithium levels is taken 12 hours. Again, plus minus 30 minutes can be there, up and down, after the last dose. After the, okay, so this is again, this has been asked. Okay, now another, again, let's talk about the signs and symptoms in lithium toxicity. So suppose a patient is on fasting. Patient is on a fast for a few days, and patient is also taking lithium, and the patient has developed some symptoms. Okay, patient has developed some symptoms. There is vomiting, there is tremors, okay, fasciculations are there. So what this is suggesting? What is this suggesting? So if you remember, there is dehydration, and as we have discussed, what will the body do? The body will try to, absorb the sodium. It will also try to absorb the lithium. So there will be increase in the lithium levels, lithium toxicity may occur. So this question has also been asked. So if someone who is on fasting develops certain symptoms, which we'll discuss, what you should do? You should check the lithium levels. You should, very good, Mank. Yes, you should check the lithium levels. Very good. Now, so let's talk about again, this may be asked. So again, when we talk about lithium, we discuss the more than 1.5 milliequivalent is when the toxicity occurs. So mild to moderate would be, when 1.5 to 2 milliequivalent per liter would be there. So mild to moderate, toxicity is there. So there will be GI symptoms like vomiting, abdominal pain, then CNS symptoms like ataxia, nystagmus, muscle weakness may appear. Then if it becomes moderate to severe, that is the levels are 2 to 2.5 milliequivalent per liter, then again more of GI symptoms like anorexia, more persistent nausea, vomiting may occur. CNS may show hyper, DTRs, deep tendon reflexes, convulsions may occur, stupor, coma, these may occur. Okay, and if it is more than 2.5 severe, then patient may have generalized convulsions, oliguria, renal failure may occur, and ultimately death may occur. So these are some of the signs and symptoms of lithium toxicity. Okay, now how do we manage lithium toxicity? Okay, it's very important to identify lithium toxicity. So we discussed signs and symptoms. Okay, you should see whether there is a condition like dehydration or diarrhea, such things can precipitate. So stop, and of course drug interaction can also cause. So stop lithium, very important. Correct hydration, correct the hydration. Then also we can start for the removal of the unabsorbed lithium from the GI tract. We can use polyethylene glycol, sodium polystyrene sulfonate. Generally activated charcoal has no role. Generally we say activated charcoal has generally no role. Okay, very limited role. In severe cases, please remember, when it is more than 2.5, we need to do hemodialysis. Many a times you have to do repeated hemodialysis, because after once the there may be redistribution of lithium is there, so it may again from the tissues may come back to the blood. So we may have to do repeated hemodialysis. So dialysis is required in severe cases. So this is important. So yes, so this is what we do in the management. Okay. Now let's come to this question again. So let us see which of the following is incorrect. No, we don't have any antidote. Yeah. Okay, so again just see. So lithium decreases, so you have to tell the incorrect. Lithium decreases thyroid function, this is correct. Thiazides increases lithium toxicity, we have discussed this, yes. Lithium is avoided in pregnancy due to teratogenic effects, yes, but it is not, we can give, but monitoring has to be done. But yes, if possible, it should be avoided. It can cause Epstein anomaly. So hemodialysis is not useful in lithium toxicity, this is absolutely incorrect. So this is the answer. Is it clear? Lithium is a very important topic. Each time they've been asking. Okay, is it clear to everyone? Right. Okay. Now, so there was another question again. There is an overlapping question. So what I'll do is, since we could not get the entire question, I'll just put up some important points. I'll tell you what questions have been asked previously, and maybe if we can get a correct question, so maybe we'll try to reframe it again. Okay, so something related with criminal responsibility. Okay, something related with criminal responsibility was asked. Okay, if you know anybody, if you can help me to frame a question, you can please type in the chat box. Okay, so still I'll tell you some important points, and these questions both in FMGE and in other exams have been asked. Okay, so let us try to talk about this. So basically section 84 IPC, this has been asked. Which section of the IPC talks about criminal responsibility. So it is section 84 IPC. This is an old question, FMG question. Basically it embodies what is known as McNaughton's rule. So basically what is this, that nothing is an offense. So criminal responsibility basically means whether a person who has some psychiatric illness, mental illness, certain things done by him, is he responsible for that criminal act. Okay, so let us say someone has thoughts that my neighbor wants to kill me. He has delusions of persecution and he fears that the neighbor will come and kill me. In that anticipation, he has in fact tried to kill, or he has killed the neighbor. So is this person responsible for his criminal act. Okay, so what is this section 84 of the IPC states that nothing is an offense which is done by a person who at the time of doing it, okay, at the time of doing the act, by reason of unsoundness of mind is incapable of knowing the nature of act, or that he is doing what is either wrong or contrary to the law. Okay, so if it is proved that because of unsoundness of mind he could not know the nature of the act, or what he is doing is wrong or against the law, then he is not responsible for the act. Okay, so this is again it embodies McNaughton's rule. Then there is something known as Durham's rule. Once in a paper in INI-CET that asked which of the following is related with the criminal responsibility. Okay, so there are certain other rules. This is again rule in the USA. Again, it is not followed anymore, it has been removed. So Durham's rule says an accused person is not criminally responsible if his or her unlawful act was product of mental illness or mental defect. Okay, because of these product, mental illness, defect, these terms, because they are not very clear terms, so they have not now it is no longer used. Okay, they have removed this. But you should know again Durham law rule is also similar. Okay, again it is talking about criminal responsibility. Then there is also something known as Curran's rule. Again it is similar. Okay, an accused person will not be criminally responsible if at the time of committing the act he did not have the capacity to regulate his conduct to the requirement of the law as a result of mental disease or defect. Again it is on similar terms. So one they had asked in INI-CET which of the rules is related with criminal responsibility, and option was Durham's rule and Curran's rule. So you should know. Okay, then in India there is also section 85, again IPC 1, last you should know, criminal responsibility of an intoxicated person. So someone is intoxicated with a substance, let us say alcohol, and he commits some crime. Will he be responsible or will he not be responsible? So again this has also been asked, so you should know section 85. Okay, so if a person is so much intoxicated that at the time of doing the the act that he was incapable of judging the nature of the act, or that he is doing what is either wrong or contrary to the law, again it is similar to what we have discussed, then he is not he has not committed the offense, provided, this is important, provided that he was administered that substance against his will or without his knowledge. Okay, that is, it was not voluntary intoxication. Then we may say that that the person is not held responsible. Okay, so if you could just tell me what question was asked. Okay, maybe we can frame, or let us see if we can get a better question, or if we can get a total question of that McNaughton's rule or what it was. So we'll try to put it in the app. Okay, so these were some of the important questions which we could recollect. Again there may be some variations. This is what we could recall. If there is any change, or is there any options we get, we'll let you know. Okay, from the options available, those were the correct answers. Okay, okay, right. So let us see. Okay, great. So this was about so if you see again I'll say, if you see, the topics were previously asked topics. Of course slightly tricky questions, some of them, but some were very easy also. Okay, so this was for a total of 6 to 7 questions at least were asked in psychiatry. Okay, now again we are also in PrepLadder we are introducing a elite pack, and which has updated and new videos. So we'll be we'll be again meeting digitally very soon. Okay, and all the 19 subjects in English and English. Okay, and also we have a next Q bank with again sync with the next 70% of clinical questions will be there, and again unique features like treasures, rapid revision, snap videos. Okay, and all the past year MCQs. Okay, so again very eager to meet all of you soon digitally. Okay, in the PrepLadder app. Okay, and also you have discounts available. Okay, so again my mantra for again all of you is keep smiling. Exam, it was just one exam. Okay, let's enjoy this day, who has these days who have given the exam, relax a bit. Okay, and once you clear this exam, maybe you can eye for then PG preparation. So keep moving forward. This is it's a field which is has a very long continuous journey, so keep moving forward. So thank you all of you. Okay, may God bless you. Have a nice day. Thank you. Thank you everyone.